Hey there, it's your friends here at Book Podcaster.
Hey everyone.
Ever feel like your brain's browser just has way too many tabs open?
Oh, tell me about it. Especially when you hit a chapter like number 17.
Exactly.
Yep.
Chapter 17 on behavior therapy.
Yeah.
It sounds kind of heavy, maybe, but honestly, don't sweat it.
Yeah, we get it.
Think of this deep dive as like your practical toolkit for understanding it.
Mm-hmm.
It's really about figuring out why we do the things we do,
Mm-hmm.
and importantly, how we can actually, make some changes.
Right. And what's great about behavior therapy, I think, is that it's structured, it's evidence-based.
Okay.
So instead of getting lost in like really abstract concepts, it keeps the focus on behavior you can actually see, observable stuff.
Right, not just feelings, but actions.
Exactly.
Yeah.
And the core idea, the really hopeful part, is that these behaviors, even the ones that trip us up, they're learned,
Okay, learned.
which means they can be unlearned or, replaced with behaviors that work better for us. It's about turning insight into actual action.
Yeah, it's less about deep dives into like unconscious conflicts from childhood, like psychoanalysis maybe,
Points of different focus.
and much more about, okay, what's happening now? What are the patterns? And how can we use techniques like reinforcement or conditioning to kind of rewire things?
Precisely. Using those principles to change the pattern.
So, our mission today, let's pull out the key stuff, the really important nuggets from this chapter,
Hmm.
so you can get a clear handle on behavior therapy and maybe see how it pops up in real life.
Sounds like a plan. Where should we start? The basics.
Yeah, let's lay the groundwork. Those core principles, classical conditioning first,
Yeah.
Pavlov.
Yep, Pavlov. Everyone thinks of the dogs and the bell, right? Salivating.
Totally.
But the key is that association. An involuntary response getting linked to a stimulus that didn't originally cause it. And it applies to us humans way more than we might think.
Okay, like how? Beyond drooling.
Well, think about emotions. The chapter mentions that example of a veteran hearing fireworks.
Oh, right, yeah.
For many people, fireworks are fun, celebratory, but for someone with combat trauma, that sudden loud bang, it can trigger intense panic automatically.
Because the sound got linked deep down to danger. It's not a choice, it's just bam, reaction.
Exactly. An involuntary physiological response. Or think about food aversions. You get sick once after eating something.
Yeah. Happened to me with, never mind.
Huh.
Hmm.
Right. And now maybe even the smell of that food makes you feel kind of queasy.
Totally. Years later.
That's classical conditioning, an automatic link.
Okay,
So then there's operant conditioning, Skinner's territory.
right. This one's more about consequences, isn't it?
Exactly. Voluntary behaviors, actions we choose to do, and how the outcomes, the rewards or punishments, influence whether we do them again.
So like the example of a child learning to use, say, calming techniques instead of having a tantrum.
Hmm.
If they get praised for using deep breaths as positive reinforcement, right? They're probably going to try that again next time things get overwhelming.
Precisely. The positive consequence makes the behavior more likely. It works, it feels better.
What if the reinforcement isn't, like, consistent? If sometimes they get praised, sometimes they don't.
Ah, good question. That's intermittent reinforcement. And actually, it can make a behavior even stronger and harder to get rid of.
Really? Why?
Think about gambling, like a slot machine. You don't win every time, but the chance you might win keeps you pulling the lever. Unpredictable rewards can be very powerful.
Huh. Okay, that makes sense. So consistency matters.
Very much so, especially when you're trying to establish a new behavior or decrease an unwanted one. Okay, next principle. Modeling.
Learning by watching.
Yep. Bandura's work, largely. We learn a ton just by observing others, what they do, and what happens to them as a result.
Like the client with social anxiety, watching someone else role play being assertive.
Exactly. Seeing someone similar to you succeed can be really empowering. It provides a kind of blueprint.
If they can do it.
Oh, maybe I can too. But it's subtle. Who we choose as a model matters. We tend to imitate people we see as similar to us, or people we admire.
Okay. And you also watch what happens to them, right? Like if they get a good reaction.
Definitely. If the models reinforced for their behavior, we're more likely to copy it. If they get punished or ignored, we're less likely.
Yeah.
Vicarious reinforcement or punishment.
Got it. Okay, two more big ones. Systematic desensitization.
Right. This one's huge for phobias and anxiety disorders. It's about gradual exposure.
Slow and steady.
Very slow and steady. You pair relaxation techniques with gradual exposure to the feared thing, starting with something minimally scary and working your way up a hierarchy.
Like that nursing example in the chapter. Helping someone with agoraphobia. They don't just push them out the door. It's maybe first imagining leaving the house while doing relaxation exercises.
Exactly. Then maybe walking to the mailbox, then down the street, each step paired with calm.
So you're essentially trying to replace the fear response with a relaxation response. Counter conditioning.
You got it. The relaxation is crucial. It competes with the anxiety. And you only move up the hierarchy when the person feels comfortable at the current step.
Patience is key there, I bet.
Absolutely. And client control. They set the pace. Okay, and then there's aversion therapy.
This one sounds less pleasant.
It can be. The goal is to reduce an unwanted behavior by associating it with discomfort or an unpleasant stimulus.
The example used was about quitting smoking, right? Taking a medication that makes you feel nauseous if you use nicotine.
Yep, that's a common one. You pair the targeted behavior smoking with an aversive consequence, nausea. The idea is to create a strong negative association that reduces the urge.
Okay, I can see how that would work, but wow, there must be some big ethical considerations there.
Huge ones, absolutely critical. Informed consent is paramount. The person has to fully understand the procedure, the potential discomfort, the risks, the benefits, and agree willingly.
No coercion.
None. And the discomfort has to be justifiable, clinically necessary, and carefully managed. It's not about punishment for its own sake. It's a specific therapeutic tool used cautiously.
Right. Okay, so those are the foundations. Classical, operant, modeling, desensitization, aversion.
The building blocks.
Now let's talk about how these look in practice, like the actual techniques nurses or therapists might use. Positive reinforcement seems pretty straightforward.
It is, but doing it well makes a difference. Rewarding desired behaviors, like you said, praising a client for being on time for therapy.
Simple.
Simple, but powerful. The key is often immediacy, reinforcing the behavior soon after it occurs. And specificity helps too. Not just good job, but it's great you made it to group on time today.
Makes sense. What about token economies?
Yeah. You see these often in inpatient settings or group homes. It's a system.
Like earning points or stars?
Exactly. Individuals earn tokens, points, whatever, for specific positive behaviors, maybe making their bed, attending therapy groups, interacting appropriately.
And then they can trade these tokens in for
Privileges or desired items. Maybe extra rec time, a preferred snack, access to certain activities.
So it creates a clear structure and incentive.
Right. Needs clear rules, consistency, and the rewards have to actually be motivating for the individuals involved. What's rewarding for one person might not be for another.
Good point. Okay, then there's extinction. This is about getting rid of unwanted behavior.
By removing the reinforcement that maintains it.
So like the example of ignoring minor attention-seeking outbursts if attention is what the person is actually after.
Precisely. If the behavior isn't harmful, and you figure out it's being fueled by the attention it gets, withdrawing that attention can cause the behavior to decrease.
That sounds hard to do sometimes, especially if the behavior is annoying.
It can be very hard. And you have to be prepared for something called an extinction burst.
Meaning?
The behavior might actually get worse for a bit right after you start ignoring it before it starts to fade. The person kind of doubles down to get the reaction they're used to.
Oh, wow. Okay. So you got to stick with it.
Consistency is everything with extinction. Otherwise, you risk intermittent reinforcement, which we know makes it stronger.
Gotcha. Okay, shaping. This one sounds kind of cool.
It is pretty cool. It's about reinforcing successive approximations, small steps toward a final desired behavior.
Yeah.
Used when the target behavior is complex or maybe doesn't happen at all yet.
Like teaching a very withdrawn client to participate in group, you wouldn't expect them to talk loads on day one.
Exactly. Maybe you first reinforce just sitting with the group, then making eye contact, then saying hello, then maybe offering a one-word answer. And you gradually reinforce each small step closer to the goal of active participation. You're shaping the behavior over time.
Celebrating the small wins.
Absolutely. Patience, breaking it down into tiny steps, and consistent reinforcement for each step.
Okay. Time out. Most people think of this with kids, right?
Often, yeah. But the principle applies more broadly. It's technically time out from positive reinforcement.
Meaning, you temporarily remove the person from a situation where they're getting reinforced, usually because of an unwanted behavior.
Right, like the child with ADHD who gets aggressive during play. A brief timeout removes them from the fun, the reinforcement, and gives them a chance to calm down.
What makes a timeout effective, therapeutically speaking?
It needs to be brief, used consistently for specific behaviors, explained clearly, if possible, and not used punitively just out of anger. The goal is removal from reinforcement, not just isolation, and the time and environment needs to actually be reinforcing.
Okay. If playtime isn't fun, removing them doesn't do much.
Good point. Okay, last technique here, flooding.
This sounds like the opposite of systematic desensitization.
In a way, yeah. Instead of gradual exposure, flooding involves prolonged, direct exposure to the feared stimulus without the possibility of escape until the anxiety naturally decreases.
Whoa, like putting someone with a dog phobia in a room with a calm dog for an extended period.
Yes, but, and this is a huge BUT.
Needs a professional.
Absolutely. Must be done under the guidance of a trained therapist. It can be very effective for some phobias, but it's intense and needs careful management to ensure safety and prevent re-traumatization. Not a self-help technique.
Definitely noted. Okay, so lots of tools in the toolkit.
A wide range. And across all of them, something we haven't stressed enough yet is the client's motivation.
Yeah. Does the person actually want to change?
Fundamentally, behavior therapy is collaborative. The client needs to be invested, willing to do the work, practice the skills. You can have the best techniques, but without that buy-in,
It's going to fall flat. Makes sense. How does this all translate into, say, psychiatric nursing practice?
Oh, it's embedded everywhere. Think about behavioral activation for depression.
Right, the case study about Mark in the chapter.
Yeah, Mark. He's got major depression, withdrawn, stopped doing things he enjoyed, low energy, no motivation.
Classic symptoms.
So the nurse using behavioral activation doesn't just wait for him to feel better. They help him schedule activities first.
Even tiny ones.
Especially tiny ones initially. Maybe just taking a shower or going for a 5-minute walk or listening to one song he used to like. Things that are achievable.
And the idea is?
The idea is that engaging in these behaviors, even when you don't feel like it, can provide small bits of positive reinforcement or a sense of accomplishment. Doing things can actually start to lift the mood, breaking the cycle of withdrawal and low mood. Action precedes feeling.
Counterintuitive, but powerful. You activate the behavior to change the emotion.
Exactly. It's about creating opportunities for positive feedback from the environment. We also see these principles heavily used on inpatient behavioral units.
Like with those point systems or token economies we mentioned.
Precisely. Patients might earn points for attending group therapy, maintaining personal hygiene, interacting respectfully, meeting certain goals.
And nurses are often the ones tracking this.
Yeah.
And giving out the praise or points.
All the time. They're observing behavior, providing that immediate reinforcement verbal praise, points on a chart consistently applying the unit's behavioral program. It helps create a structured environment focused on positive change.
So it's really woven into the fabric of care.
Very much so.
Yeah.
But with all this power to influence behavior comes responsibility, right? The ethical side.
Yeah, we touched on it with aversion therapy, but it applies broadly.
Absolutely. Informed consent is always key, especially if using potentially aversive techniques or restrictive ones like timeout. Ensuring dignity and autonomy is paramount.
We're helping people change, not controlling them.
That's the line. Avoiding manipulation or coercion. Applying consequences or reinforcement fairly and consistently. You can't play favorites or be arbitrary.
And making sure the plan fits the person.
Right.
Like it's appropriate for their age and situation.
Crucial. Nurses need to collaborate with the whole treatment team, psychiatrists, therapists, the client themselves, to ensure any behavior plan is safe, ethical, respectful, and developmentally sound.
Lots to keep in mind. Okay, so wrapping up. Behavior therapy. It's structured, it's practical,
Focused on observable behavior based on learning principles.
and it offers a whole range of techniques, from simple reinforcement to more complex stuff like shaping or desensitization.
All aimed at helping people make tangible changes. But as we said, client motivation is the engine.
Definitely. It's a powerful lens for understanding why we do what we do.
Yeah, and once you start understanding these principles, reinforcement, conditioning, modeling, you kind of start seeing them everywhere, don't you?
Totally. In how ads work, how kids learn, how we train pets, even how we interact with each other day to day. It makes you think.
How do these subtle reinforcements shape our own habits and our relationships? Something to chew on.
For sure. All right. Deep breath, everyone. You are absolutely getting this stuff. You're tackling it piece by piece.
You really are. Keep going.
And hey, seriously, give yourself some credit. This isn't easy material. Maybe go grab that snack or do something nice for yourself after this. A little positive reinforcement, yeah.
Perfect example.
And just Be kind to yourself through the whole learning process. You really got this.